Well, welcome to the 2014 annual Brian Pridmore Perinatal Forum. For those who may not know me, my name is Brian Weekly, Chair of the Education Subcommittee of the South Australian Maternal, Perinatal and Infant Mortality Committee. And this is the 18th year that this event has occurred. We held the first such event in 1997, and then following the death of the founding chairman, Dr. Brian Pridmore, it was decided to name the forum in his honour, and the first forum bearing his name was in 2007. And the popularity of these forums is testified to by the enormous support that you and others have shown by your enthusiastic attendance over the years. So we say thank you very much for that. It wouldn't be possible without you, and it has remained a challenge to decide whether or not to limit numbers, as there is such an enthusiastic response as soon as the next year's flyer appears on the wall or wherever it might go. Now, we're not really resourced to find a bigger venue, and so and all the logistics that would go with that. So we are sorry if it's a tight fit at times, and to anyone who has had to be turned away. You may have realised that the event is being recorded, and an edited version will appear on the South Australian Health website in due course. This proved very popular last year, testified again to by the number of hits, and it opens up the forum to our rural and regional colleagues as well. So welcome, and thank you to Chris Sprod, who is a senior photographer and digital media expert from the Centre of Education and Training here at the WNCH, and we thank you for your valuable support and making sure all the microphones work as well. And to that end, microphone, because it is being recorded, when there is an opportunity to ask questions, we could just ask you to wait until a microphone appears in front of you so that what you are asking or commenting on can be adequately heard. I would also publicly at this stage like to thank Dr. Darren Roberts for his contribution. His membership of the committee and role as MC over the past 5 years is keenly missed. However, it does give me great pleasure to welcome to the committee two new members, Drs. Morgan Vitani and Amy Riley, who will be contributing to tonight's forum. The other members of the committee remain midwife Julia Ratz from the private sector at Burnside, neonatologist Dr. Vanish Bhatia, and Drs. Wendy Shield and Ms. Robin Kinnair from the Pregnancy Outcome Unit. So the topic for tonight, as with every year, is drawn from the feedback that each audience provides. So please complete the evaluation sheets, whatever you might think. We do read them and assess them and work out what should be done in the future. There are also signed attendance certificates that have been placed on your seats if you need those for CPD purposes. And finally, before we get underway and I introduce our panel, one of the charters of the Education Subcommittee is to present the summary of recommendations published in the most recent annual report of the Maternal, Perinatal and Infant Mortality Committee. These annual reports that everyone sees in due course are by necessity published after review of the members of the main committees, and those reports often are lagged behind the year because of the fact that they are gone into so diligently, and they consider the responses based after looking at other areas of wisdom such as the coroner's reports and national and international specialist bodies. So the current recommendations, and you'll see for 2012, because the report that's about to come up towards the end of this year is for the 2012 calendar year. These are the recommendations, and again these were things that have been identified from real cases and perhaps contributed to an adverse outcome. To reduce the risk of confusion about the urgency of caesarean section, it's advised that all hospitals must use the terminology and the standards for the management of Category 1 caesarean section in South Australia 2011. Second to last, women at increased risk of preeclampsia should be treated from early in pregnancy, that being described as less than 16 weeks gestation, with aspirin 100 milligrams daily to reduce the risk of early onset preeclampsia with intrauterine growth restriction. And finally, the committee is discussing with the Maternal and Neonatal Clinical Network and clinicians and other clinicians whether routine antenatal vaginal screening for Group B streptococcus remains appropriate. Watch this space. I had nothing to do with writing all these, I'm just passing them on. So anyway, it'll be an interesting thing to see, and as we know, it's not universal to have GBS screening within Australia, let alone around the world. So, without further ado, I'd just like to introduce our tonight's panel for Q&A. In order from your left to your right, we have Associate Professor Chris Barnett, Head of Paediatric and Reproductive Genetics and the South Australian Clinical Genetics Service, which is based here. We then have Hazel, I think, is that right? Hazel, who is Midwife Coordinator of the MFM and Antenatal Diagnostic and Counselling Service here at the Women's and Children's Hospital. And then we have Dr. Jay McGavigan, Consultant Obstetrician and Gynaecologist and Head of Maternal Fetal Medicine from the Department of O&G and Reproductive Medicine from Flinders. And on her immediate left, we have Dr. Michael Metz, who's Consultant Clinical Pathologist for SA Path at the Women's and Children's Hospital, as well as Director of Clinical Chemistry at ClinPath. So with that illustrious panel, we should go home with our brains stacked full of knowledge tonight. But thank you again for willing to do that. And again, please remember this forum is meant to be interactive, so please don't feel frightened about asking a question or making a comment. But do please wait, if you can, till a microphone reaches you. And no question is unimportant. The meeting is for you, us, to learn. So if you feel it's a question that everyone else knows the answer to, that doesn't necessarily mean they do. So please go ahead. Right, so first of all, I'm going to invite Amy Riley up to present the first case, which will act as a jogger for our first lot of discussions. Thanks, Amy.
Thank you. And thank you for allowing me to start with this first case. And as we go along, I'll ask a few questions of the panel, but as Dr. Wheatley said, if anyone has any burning questions as we go, please pop your hand up. Morgan Vitani here will be our little microphone runner, so she'll run down and hopefully get it to you in time. So this first case is an 18-year-old primip who had an unplanned pregnancy, but had a dating scan early in pregnancy to confirm her EDC, and she booked in at 12 weeks gestation. Now she was underweight with a BMI of 16 at booking. No significant past medical or surgical history, but smoked at least 10 cigarettes per day and 4 to 6 cones of marijuana per day as well. At her booking visit, she had one of these maternal serum screening tests offered to her, the first trimester screen, and I thought we could start with, I guess, our first lot of questions to the panel really, and I don't know if anyone in particular would like to put their hand up and I guess sort of say, I mean even, I guess Hazel could, I suppose, if she wanted to. Just as at their booking visit, the things that are important that we should be putting on this form.
The short answer is all of them. I certainly can expand on that. I think we all have prepared brief discussions, but the first trimester, particularly the first trimester screening test, is an extraordinarily complex calculation that includes just a ton of variables, and really all the dates, all of the data that's requested is used in SAMSAS here for interpretation, generating the risk. Particularly important things, well, we need to know who the person is, but gestational age is critically important. These days, with the use of ultrasounds, we have good gestational age estimates. In the old days, before we did a lot of ultrasound gestational age dating, a third of the high-risk results were a function of incorrect gestational ages. And are they incorrect? The others, there's a huge number of very strict conceits in doing this calculation. But that's very important. Really, twins is important. Maternal weight is extraordinarily important. So I would say all of them for the short answer.
May I just ask what the significance of or could you expand on the significance of the ethnicity of the woman is, please?
Yes, ethnicity is useful, particularly Caucasian versus Afro-Caribbean, which isn't a huge population we deal with. But the median marker concentrations vary by race. Now, Aboriginal, South Asian, and Oriental, they're a bit soft, but it's a way to collect data to improve our risk generation. But clearly, African and Caucasian, different analyte concentrations.
I'd like to know the significance of IVF. Is that significant?
Yeah, okie doke. Well, IVF, we calculate risk based on the donor, the egg donor's age. So if this is IVF that's a donor egg, we don't use the maternal age for generating risk. We use the egg donor's age. And, you know, if you tick IVF, we'll look at that. And actually there are, it seems, I'm really pretty confident that it does affect the calculation in other ways.
So, our patient opted to proceed with first trimester screening, and we've got a result form similar to this, although this has no results in it. So I'm going to click over to our OASIS result page. And I guess here we can start going through each of our specific results that we look at in our first trimester screen. And so for her in particular, we can see that she has had everything ticked and answered on her form, but she had a low PAP-A. So I thought I would throw it back at the panel if someone would like to talk to us a little bit about, very briefly, about PAP-A. I guess firstly, all of it, yeah.
So PAP-A is also known as placental-associated plasma protein. Close, yep. Produced by the placenta. And we use it in screening, not only as a marker for aneuploidy risk, but also as a sort of a surrogate marker for uteroplacental function. And when we get values that are less than 3 multiples of the median, it starts putting up flags that maybe the placental function may be a little bit dodgy later on in pregnancy. Women with these low levels can be at increased risk of preeclampsia, stillbirth, IUGR, and fetal growth restriction. So what we do in South Australia is we generally carry out uterine artery Doppler screening around the time of the morphology scan, again as a further possible marker of uteroplacental function, and do growth scans for these women at 28, 32 and 36 weeks.
I'd just like to make a comment that she's a smoker and you should really recalculate this through the lab because it might change her risk.
Yeah, smoking tends to reduce their risk, but we don't like to make that publicly known.
Can I probably should have asked this question at the question before. Given that the screening test and then the implications for the rest of the pregnancy, and given so early, what would you recommend as the basic level of counselling? Because before they actually have the screening test, so that women actually understand where this path can lead them. Because a lot of women that you meet them after they've had the screening test, and then there's a whole journey then set out on, some soft markers, some harder markers, and there are decisions that they hadn't even considered. And so I would just like to know what the panel thinks is the basic level of counselling that a woman should have before she even has this test.
I think it's you have to make it very clear to them from the start of what it means and why they're doing it. I generally say to patients, I guess the whole premise of screening of this form of screening is to look for aneuploidy. And if patients indicate that they would never consider termination of the pregnancy or any further testing, then I explain that there's not a lot of point in having the test because it just starts a lot of angst. So I think it's very important to explain what it's for and what will happen or what will be offered in the event of a high-risk result, and that they need to be aware of these options and if they wish to pursue them before actually starting on this journey of having the screening test. And I think there's a lot of young people or pregnant women in particular who they're so overwhelmed with all the information they receive at the booking visit, and they get their form for their booking bloods and it's, oh yeah, I'll just take this and I'll do this and I'll do that, without actually really getting a grasp on what it means.
The concept of risk is a really hard one to understand because it's not black and white. You know, most tests you go for, you've either got diabetes or you haven't, you know, in people's history generally. And when you're just starting to discuss, I mean, like the low PAP-A, that can set somebody on a, you know, on a course of lots of extra ultrasounds, which are not, you know, just working clinically with women. Sometimes they're set down a scale, and it actually can be quite distressing because they think then there's something wrong with their baby. And the concept of risk is hard even for professionals to, you know, to understand.
I totally agree. Often when I see women in my amnio clinic and CVS clinic and go through it with them, I actually say to them, look, you know, this risk of 1 in 250, it's a number that we would regard as a high risk, but you might not necessarily. You know, I've had a 45-year-old woman who's had 10 cycles of IVF, who has had screenings, come back with a risk of 1 in 3, and she was over the moon because she said, that means 60% of these babies will be absolutely fine. Whereas you've got 18-year-olds with a 1 in 20,000 risk who say it's still not good enough, and I need to know. So risk is, and I reiterate to them that risk is very much what you perceive as high and low. So this 1 in 250, it's from our statistics, this is what we would regard, but that might not be a high risk result for you.
Can I just make a comment too about the test itself? Because a lot of people don't realise that although all of the biochemical screening is done through this hospital, SAMSAS, the result that you get as a public patient may well be different to the result that you get as a private patient. And that might surprise people to hear that, but the reason for that is that the nuchal translucency is given much more weight when the private algorithm is used, and we use much more weight on the biochemical markers. So you can have the same numbers, but a different risk for trisomy 21. And there was a case recently that I reviewed where using the Nicolaides program, because the nuchal was high, a high risk for trisomy 21 was given, but the beta-HCG didn't look at all like the fetus should have trisomy 21. And when we put it back through SAMSAS, the risk was readjusted and in fact was not high risk. So the important thing to know is that within the women's and children's, those figures are provided to the private sector, which are then plugged into a database to give a risk. For public patients, the risk is given by SAMSAS, and that risk takes the nuchal translucency into account, but with much lesser factor for it than in the private sector. So that's something that people don't understand about the test.
And there are a couple of different equations out there used by a variety of people. The other thing I'd comment is that we here, with my SAMSAS hat, is we try to give a result. And if you ask for a first trimester screen and the patient rocks up a little bit late, well then, you know, the second trimester screen does include neurotube defect screening. And, you know, if you're not looking to find out about the risk of neural tube defects, that's a real issue. So I mean, I honestly think that, you know, the minimum information to give people is probably more than you have time to give them.
Can the panel explain about the free beta-HCG as well in there?
It's good. I mean, it's 0.93 moms. Moms are multiples of the median. That's just about the median value. That's just about the 50th percentile. That's good. Now, the relative ratio of the beta-HCG to the PAP-A is high, which would increase your trisomy 21 risk, but that's a good, is that a good answer?
It is a good answer, but if it's a low PAP-A, is that something you look at as well and consider to have a...
Yes.
To watch the pregnancy for other issues?
Yeah. Well, one of the interesting things about the serum screening is that it's really not just for aneuploidy. It was developed for aneuploidy, but we've used it for a while. We've looked at it very closely, and we've identified other components. A low PAP-A is a very potent marker of which contributes significantly to determining high risk for trisomy 21, but it's also a significant risk for adverse outcomes. Now, people have looked at reporting PAP-As of less than 0.1 moms, and actually the majority of pregnancies with a PAP-A, even in that range, do very well. But a low PAP-A by itself is still a bit of a risk factor. Additionally, a low PAP-A and a low beta-HCG And that's a comment that you'll see from time to time where, while the patient isn't determined to be at high risk for aneuploidy, the analyte results are outside the normal range. That's another significant risk marker for an adverse outcome. Fetuses that have low PAP-A, low beta-HCG, but don't have high risk for aneuploidy, there's about a third of those pregnancies will be successful. The other 2/3 will be difficult. There's a high rate of fetal wastage with those values.
Sorry, just a quick question with regards to the SAMSUS result. My understanding is at the moment, if you get a low PAP-A, there's no recommendation from SAMSUS about further screening in terms of uterine artery Dopplers and morphology. Should there be?
There is on the SA Perinatal Practice Guidelines.
Yeah, but it doesn't come out in the report.
No, it's not. It's not on the report, but it is on the guidelines.
So this patient, whilst she did have this low PAP-A that was picked up, she still remained low risk. And so she went along at her 20-week scan she had here at the Women's and Children's, and at the same time as her morphology scan she had uterine artery Dopplers performed, which for her all came back normal, but I thought this might twig some more questions perhaps about uterine artery Dopplers, which I have popped a little picture of on here, but I don't know, Jay, if you wanted to talk a little bit about uterine artery Dopplers.
So we sometimes look at uterine artery Dopplers in women that have maybe had severe preeclampsia in a previous pregnancy, severe early onset IUGR, almost as a marker to try and predict what their placental function is going to be like in the current pregnancy. And what you want is, really, I haven't got a pointer, but you want a nice waveform like the first image that you can see there, with no evidence of notching, so it's a nice low resistance waveform. And in the second one, you can see that there's a little notch just there where the arrow is, and the resistance index is much higher and outside the 95th centile for gestation. And what that means is that this placenta possibly has got issues with its implantation. And secondary to this, uteroplacental blood flow may be compromised, and therefore you're at increased risk of IUGR, stillbirth, early onset preeclampsia.
I was wondering if you could comment on the significance of a unilateral, say, abnormally high or notched uterine artery as opposed to bilateral. Like, is it a continuum or is it only bilateral that gives you that increased risk?
It depends on which side of the uterus the placenta has implanted that can affect the blood flow. We often see unilateral, I mean, I guess notching is quite subjective, and we do often see unilateral notching. I tend to get more anxious if it's bilateral.
So this patient went on to have further scanning, and at 24 weeks was found to have a double bubble on scanning. So something popped up there which wasn't seen initially on morphology scan. So she went on to have a scan at 27 weeks to assess growth, Dopplers and AFI. And at that point, again, confirmed the double bubble finding, which was suggestive of a duodenal atresia. But no other abnormalities were seen. And at that point, growth was on the 19th percentile. But her next scan started to show something a little bit different, and at that point we saw that the growth was dropping off. So her estimated fetal weight of this fetus was on the 8th percentile now. And again, she had the double bubble was noted on scanning. So I guess another thing that we could, and it's I guess beyond the scope of this talk, but really thinking about how we'd compare a small for gestational age fetus with a growth restricted fetus. Anyone like to?
I mean, it's tricky, and this happens every week, as you know, at ADAX, where there's a baby that might have short, long bones. And, you know, is that a bone dysplasia? Is it a baby whose parents are small, which it often is? Or is it a baby that is small because of the placenta being abnormal? And I think there's ways of getting closer to an answer, but often we don't have an answer. We have babies who clearly have IUGR at delivery who have had normal Dopplers and have had nothing other than normal rate of growth during the pregnancy. I've seen 2 babies who have, where parents have been told that the likely diagnosis was achondroplasia, which is the commonest form of dwarfism, and in fact they were normal, small babies from parents who were small. So it's tricky, and I think the further along you go in the pregnancy, the harder it is to tell what the actual size of the baby is sometimes. So, I think if the papae is low, the placental function is in question, then obviously our alarm bells are going off. The other thing is, for a condition like Down syndrome, there's no, the baby can of course have absolutely normal growth. Trisomy 13, usually absolutely normal growth. Trisomy 18, always IUGR. So there are patterns that follow with different conditions.
Yeah.
We didn't really elaborate further, but clearly this particular case is heading in the direction of Down syndrome with the double bubble. For those that haven't heard of that before, it's highly associated with Down syndrome, duodenal atresia. And I guess the key question here is first trimester screening hasn't told us that this baby has Down syndrome, but it has. And obviously that's an important point for Michael to make. Why hasn't it told us that this baby has Down syndrome?
It's always a tough one. It's a difficult one, because really, by and large, if you turn up at low risk, you're really very, very unlikely to be carrying an affected fetus. The negative predictive value for first trimester screening is in excess of 99% most of the time, and it's well in excess of it much of the time. I think it's a matter of the distribution, the calculations. I've been a bit slack. What is her weight?
It's 47 kilos at 14, so BMI 16.4.
Yeah, that's interesting, because as I mentioned, the beta-HCG PAP-A ratio is the sort of ratio you'd expect to see. She's very small. We have default weights, but we also there's a limit of weight in the calculation. Perhaps forcing that weight into the calculation might make a difference. But really the bottom line is that this is based on a huge amount of empirical data, and it isn't perfect.
Might also ask Hazel, perhaps to give us an idea from the MFM midwife side of things. You've got this patient coming into clinic. What sort of things are you talking to her about? So, saying up until now, really 27 weeks, that we were starting to think perhaps there might be something more going on. I guess from your perspective, what sort of things do you talk to her about, or would you?
Well, I guess first thing, in view of her the duodenal atresia, we would refer her to the paediatric surgeons, so they can talk to her about what may be required afterwards, and anyone else that she may need referred to, paediatrician obviously as well, planning around the delivery, and just general counselling, and what support she's got, if she requires, we'll find out about her family supports her, if she has a partner, and maybe social workers as well. And also, because of her weight, she's obviously got some issues. Her history is important. Oh, sorry. Is that on?
I think it is pushed up, yeah.
Obviously her history, and what supports are there. So social workers, mental health possibly, if she's got an eating disorder, just make sure that we've got all those people in place. And any additional supports, just general counselling, making sure she's got enough, with her visits. We'll see her regularly. She's got contacts, and she knows the availability of us. It's usually, because we follow these women up quite closely. Obviously, with her growth restriction as well, she'll be coming back regularly for visits and scans. And just making sure she's got all that ready for birth, a plan in place.
The other thing is there's still a role for amnio here. We often don't talk about it after, I guess, viability, but planning for delivery here would be important to know. It's likely to be trisomy 21. The risk, of course, isn't miscarriage. The risk is prem labour. So timing an amnio, somewhere in the mid-30-week stage to make a definitive diagnosis of Down syndrome might be helpful for the family, might be helpful for decision-making in the first couple of days of life, potentially.
So the outcome, she has delivered, and I believe karyotype is still pending, so she didn't have an amnio, but she delivered preterm. She went into labour with her high AFI, 31 centimetres at this time, but got a little bit further along. So yes.
I've got a query about the femur length. So I know that's one of the soft markers of the short long bones for your aneuploidies. Is that the same at any gestation, or is it simply at that morph scan if they've got short long bones there? Because I've seen a few come through with short long bones at 30, 32 weeks that weren't necessarily less than the second at their morph scan.
Good question. The first thing is, again, the most typical and well-known form of dwarfism, achondroplasia. Femur length is normal at 19 weeks and it becomes abnormal in the second half of the pregnancy. So there are conditions like that. In fact, there are quite a few bone dysplasias that are like that. So it's indexed to the gestational age.
Well, good evening. I was given the brief to discuss the biochemical screening, and the difficulty is it's really not just biochemical screening. We can offer biochemistry-only risks, but they really aren't as good as a combination. And the point I'd really like to make is that SAMSAS and really any antenatal serum screening scheme uses maternal age, a gestational age, ethnicity, weight, medical history, smoking, diabetes, things like that, past obstetric history, nuchal translucency, and of course serum biochemistry. And these are used to detect trisomy 21, trisomy 18, neural tube defects in the second trimester, but also failed pregnancies, feeble pregnancies, troubled pregnancies, pregnancies affected by other conditions, and a few very unusual conditions. It's more than just aneuploidy screening. Screening options that are generally available is first trimester blood, 9 weeks to 13 weeks, 6 days, with an ultrasound from 11 weeks to 13 weeks, 6 days. And second trimester really flows on from the end of first trimester as we define it at 14 weeks to 20 weeks and 6 days. Now, I think it's interesting that we actually talk about 13 weeks, 5 days, 13 weeks, 4 days, because I would suspect that you rock a pregnant woman up to 6 obstetricians and ask them for their gestational age. And if you ask them on 2 days, you'll get 15 different gestational ages. It's a highly structured, highly conceited scheme and a bit artificial. And of course, we do combinations. First and second trimester serum screen combined is actually a very effective predictor. You can add a nuchal translucency to that and get an even better result. There are some places that do this multi-screen. The difficulty with it is that if you do first trimester biochemistry, nuchal translucency, and then wait for a second trimester serum screen, you've got results that might be good to act on. And you also have a fair bit of anxiety. I've had the first test, when do I get the second test, when do I get my results? Having said that, with all of that difficulty, it's a very good predictor. And you can do NT-only screens, and of course, second trimester serum screening. And what I mean by that as well is you can do a first trimester nuchal translucency. If the serum misses the first trimester window, we can combine that with a second trimester serum and get a risk that's better than either of those alone. Very briefly, as you know, the risk for chromosomal abnormalities increases with age, and it continuously increases. The gestational age-related risk for aneuploidy decreases with gestational age. A woman at 6 weeks has a greater risk of carrying an affected fetus than she does at 12 weeks, and that again, there's a fair bit of fetal wastage. And so you can see the combination of these two adds a level of intricacy that's a bit of a challenge. My particular, a bit of a bugbear I have is maternal weight. I made 2 calls today to tell people that we determined high risk for trisomy 18 in a couple of pregnancies, and the weight would make a difference. If you think of it, the fetus is about this size and women's size varies a fair bit. This is a median, or this is a distribution of weight in Belgian pregnant women from 2009. And you see pregnant women, there's a huge distribution. And what happens is these biochemical markers are made by the fetal placental unit and released into maternal serum, and we measure them in maternal serum. A big woman has more serum, so you get smaller concentrations. A small woman, as is the case, has smaller serum to dilute things in, so you get a higher concentration. And you can go from a normal risk to a trisomy 18 risk, clearly, to just an adverse outcome risk based on maternal weight. Typically bigger women, and it's not obesity, it's gross weight. So a tall, muscular woman with the normal BMI can generate a significantly adverse result if we don't know those figures. But the biochemistry itself, this is just, pregnancy is an interesting time. You blink and it changes. The red line is beta-HCG. As you know, they fall from a peak of about 10 weeks to delivery. The green line here is the PAP-A, which is really a silly name for anything, and you can see a steady increase for the first trimester. We don't have data on second trimester because we don't measure it then. The UE3, unconjugated estradiol, increases again from the second trimester through to the end of the second trimester, and alpha-fetoprotein increases throughout. The reason for this, and the fact that these are homemade assays. These are immunoassays detecting proteins or steroids circulating in blood. Each manufacturer has their own. There's a number of these don't have international reference materials. Harmonization varies. The results you get from one assay may well be different than the result you get from another assay. To try to sort all of this out, Nicholas Wald came up with the idea of median values and using multiples of the median. And the point of that is that you can see if you measure the population, in fact, these are median values. As you look at population changing, concentration changes through pregnancy, you'll get the median value, the 50th percentile value, and then you'll get variation from top to bottom. This is beta-HCG values in affected women, in pregnancies or of fetuses with trisomy 21, compared to the normal distribution. Why did this young woman not have a positive SAMSAS risk? Well, here's the beta-HCG in somebody with carrying trisomy 21. There's a fair bit of variation. But looking at multiples of the median, you can try to normalize for gestational age and for method of measurement. As you go through pregnancy, increased multiples of the median for beta-HCG by itself are associated with an increased risk of trisomy 21. Likewise, decreasing multiples of the median of PAP-A are associated with increased risk of trisomy 21. There's not many straight lines in any of this. There's lots of curves. What analyte results would one typically see in a normal first trimester screen? You'd expect a mom of 1 for a nuchal translucency, alpha-fetoprotein, beta-HCG, and PAP-A. What do you see with the Down syndrome? Typically, Down syndrome affected first trimester screen, and that's the beta-HCG high, PAP-A low with an NT high. You can see with the box and whiskers, the top and bottom percentiles, there's still a fair bit of spread. Now, this is actual genuine data that we've determined. And that's a horrible slide to look at. Looking at it a bit better, these are patient ages. And so for maternal age of 31, risk at time of screen, which is maternal age risk plus gestational age screen, in a first trimester screen is 1 in 390. Now, women at 34 years of age, we would determine about 5% of them would be at high risk. They'd get a high risk result. Now, in that population, we detect about 86% of the affected pregnancies. Now, what does that turn out to? And again, we issue 1 in 4, 1 in 5, 1 in 86, 1 in 322.4. For these calculations, it's high and low, and partly that has to do with the complexity is just beyond us, frankly, to determine what's the risk for 1 in 4. Looking at the risk for someone who's high risk, the likelihood of having an affected pregnancy, it's 1 in 22. Now, the risk of having an affected pregnancy in someone who's is screened low risk, that's 1 in 2,662. So that gets back to positive predictive values. You know, the likelihood that a positive result is going to mean you've got an affected fetus, that's about 5% at 34 years of age. The negative predictive value, what's the likelihood of having an affected, the likelihood of having a normal pregnancy with a normal screen is really more than 99.9%. Now that's a lot of information, and that's for one age, for the first trimester screen. Now that's actually known across the screening age. It's an extraordinary bit of information, but the main point of that, I think, is that negative predictive value is really very high. So antenatal biochemical screening is really very complex. It's multifactorial. It's highly structured, and it's actually a very effective screening scheme. And that would be my discussion. I'd be happy to answer questions if anyone have any.
I just have a question about a case that I came across. Had a baby that I was looking after that ended up having a chromosomal abnormality. It wasn't Downs or anything like that, just a translocation on something. I don't know. Anyway, so she missed the first one, the first screen. She had a second trimester screen. She came back as an increased neural tube defect risk, but like a 1 in 1,999 risk of Downs. How does that correlate? Like, how can you get high risk of neural tube defect? The baby didn't have any issues in that respect. It was this chromosomal thing. Yep. How does that all work in with that?
The neural tube defect is really based entirely, and the SAMSAS screen is based entirely or almost exclusively on the alpha-fetoprotein. And alpha-fetoprotein is increased in a number of conditions. And really, while the aneuploidy screening is very variegated, there's lots of curves. The alpha-fetoprotein is high or low, and actually I don't really know the positive predictive value of our alpha-fetoprotein for detecting neural tube defects, but there's a number of causes for an increased alpha-fetoprotein. Recorded.
I'm really impressed with the negative predictive value of more than 99.9%. I was just curious what the sensitivity was and if that was also higher than other screening programs.
It's detection rate. Our detection rate's about 87%. From that data, it's actually a little bit higher than that currently.
Just a question on ICE users and THC. You seen any specific problems in the biochemical analysis of the pregnancies of those women, since they're certainly on the increase?
Yep. I'm actually not aware of any. Kwa, are you aware of any? Have you seen anything, any association coming through the lab? Oh, I mean, the jargon meaning THC and ICE?
Yeah, what is it?
Well, THC is pot, essentially, unless you've got better pot, marijuana, tetrahydrocannabinol, and ICE is speed, methamphetamines. Yeah. And I'm not really aware of any associations, but are you?
No, we haven't. We've saw some in the last year or so, but we don't incorporate them into the algorithm. We're only using for smoking status,
yep,
which usually affecting the PAP-A.
Yep. So
in a
are
good
you saying
way, yeah.
that you're impressed that you're seeing changes in markers due to THC and ICE? Or you're just seeing more specimens coming through?
No, we haven't seen a lot of them.
Yeah.
Or they're not telling us.
Yeah. No.
So this is just a second case to explain more about the NIPT test. This is about a 40-year-old woman, and this is just a draft to just show you that the risk of Down syndrome increases with the maternal age. So at about 40, the risk to have, depends on which child you look, but between 40 to 44, the risk to have a baby with Down syndrome is about 1 in 65, 1 in 66. So this is a 40-year-old woman, first pregnancy, no other issue. The weight is normal. she's Caucasian, everything filled very nicely up there, and that's what we get back during the first trimester screening. So the risk of the Down syndrome is 1 in 151, which is, if you look at her background risk of 1 in 83, it's actually good. So there is probably then when we can think about what to offer after this. And it's very much why Dr. McEvingan said that some people may accept the risk of 1 in 150. Anyway, this is what basically then the NIPT comes. And I don't know if you want to have a talk about this draft, or are you talking later?
Maybe I'll
yes.
Well, I can do it now.
Yeah.
Hi, everybody. It's really nice to see so many familiar faces. Having worked in the private and public sector, I think I know about 98% of you people. Probably one of the few people that knows almost everybody. I just want to quickly explain this technology to people, because many people have heard of it, but not necessarily fully understand it. So apologies for those that do understand it, but I'm just going to go through it step by step in about probably 6 or 7 minutes. I think everybody knows that that's what a cell looks like, and that most of our DNA is inside the nucleus of the cell, and that's been known for a long time. That's where our chromosomes reside. But what people haven't realised is that when cells fall apart, when they die, that DNA actually gets released into our circulation, male and female, into these tiny little sections of DNA that float around and live for a relatively short space of time. And whilst that's become the focus of this new technology, the amazing thing is that's been known since 1948 that happens. That's the first publication that described these little bits of DNA floating around outside of cells in the blood at this French publication from 1948. So all along, there's been this thought, could we do something with that rather than have to use the DNA that's in the nucleus? If you take a maternal blood sample, then there's this cell-free DNA floating around. So it's not in cells, it's stuff where cells have fallen apart and the DNA is sitting out there in the bloodstream. It's really short, 150 to 200 base pairs in length, which is just absolutely microscopic, and it's floating around. Now, it became even more interesting when it became clear that when a woman's pregnant, the placenta actually produces its own cell-free DNA, and that floats around in the maternal circulation as well. And I've represented that here in blue for the fetal and green for the maternal. When I say fetal, it's placental, it's fetal placental. And you can see that with that floating around and representative of the fetus, wouldn't it be great if you could take a sample of blood from the mother and somehow get to the blue stuff to try and work out whether there's genetic alterations in the fetus floating around in the mother's circulation. There's some really interesting properties about this cell-free fetal DNA. It lasts only for 16 minutes after it's released. It's cleared very rapidly post-delivery. 10 to 15% of all of the cell-free DNA in a maternal circulation during pregnancy is fetal. So it's not a tiny amount, but the fraction of it is still very small. Reliably detected after 7 weeks gestation, so it's in the circulation from the fetus from 7 weeks. The big, groundbreaking study was this one from 2008, where a new technology which was called shotgun sequencing sequenced those little tiny fragments of fetal DNA in the maternal circulation. Shotgun sequencing, without going into a lot of detail, just enables massive amounts of sequencing to be done over and over and over so that the tiniest amounts of DNA can be sequenced. And this was even though the stuff had been known about since 1948, this was really the key change, that you could do that. And basically the process then is this. It's simply that the DNA is not actually particularly identified as fetal versus maternal, but tiny little barcodes determine bits of chromosome 18, bits of chromosome 13, bits of chromosome 21. And using these sequences where you can now sequence the tiniest amounts of DNA, you can actually determine whether the proportions of those chromosome content is normal. And you can see here on this side, you've got a normal amount of chromosome 21 genetic material, and over here an excess of chromosome 21 genetic material floating around in the maternal circulation. So there's going to be hers and there's going to be fetal chromosome 21, and it essentially weighs more. It calculates out as being too much of that floating around in maternal circulation, with then the assumption made that that's trisomy 21. So this was a groundbreaking publication that was published earlier this year. Diana Bianchi is from the US, and essentially they looked at exactly that, DNA sequencing versus standard prenatal aneuploidy screening. And I guess one of the major take-home messages is that for trisomy 21 and trisomy 18, if you compare non-invasive prenatal testing here to standard screen, what they mean by standard screen in this paper was basically what's done in the US averaged out. So some is first trimester, some is first trimester plus second trimester, and they used what is done in all of these centres as an average. And you can see here that the false positive rate using first trimester screening averaged out was 3.6% versus 0.3 for a false positive rate. And less of a difference between trisomy 18 for the standard first trimester screening versus non-invasive prenatal testing. But this does, of course, equate then to a big reduction in the need to do an invasive test to prove that the fetus does or does not have trisomy 21 or 18. I just want to explain, we're throwing around sensitivity and specificity, etc., like we often do, but basically sensitivity, as you can see from this paper in the New England Journal, that's the probability of a positive test given that the fetus definitely has trisomy 21. That's very good, as Michael said, for both for the standard first trimester screening, but it's equally good for non-invasive prenatal testing. Specificity is the probability of a negative test given that the fetus definitely does not have trisomy 21. Again, very good for both. The positive predictive value is an important one, and that is where there is a big difference between the non-invasive prenatal testing and the standard screen. So for trisomy 21, non-invasive prenatal testing, what a positive predictive value is, it's the probability that women with a positive test on that screen, that they pay their $500 or whatever dollars it is, the probability that they're truly carrying a fetus with trisomy 21 is 45% for NIPT versus 4.2% for the averaged standard first trimester screen, and similar figures for trisomy 18. So it's held up often, that figure, as low, but when compared to traditional first trimester screening, it's in fact significantly higher. And the negative predictive value is very good for both. So basically, in essence, the summary of all that is that the specificity and the positive predictive value are higher for non-invasive prenatal testing, and the false positive rate is lower. And that's really the message. In terms of the companies, as people know, at the moment, it all goes to the US. There are multiple companies, different costs, anywhere between $500 and $1,000. Some offer screening for twins, some offer screening for sex chromosome abnormalities. Some offer, are starting to think about offering expanded testing on maternal blood for things like microdeletion syndromes, so not trisomy 18, 13 or 21 just, but also for things like 22q microdeletion syndrome, which is one of the commonest deletion syndromes where you're missing a bit of chromosome 22, which is strongly associated with neurodevelopmental outcome, cardiac disease, etc. So, and we're in, actually, this hospital is in active discussions about having our own NIPT available for South Australia. So I've got some more to talk about later, but that was really all I wanted to say about NIPT.
Placental, you said it's placental fetal. That means raises the issue of mosaicism.
Yeah, that's correct. And that's why I made the point, actually, that essentially it's becoming very clear that that is a risk, and that it may not detect
mosaicism, or it may detect mosaicism. And the companies, I think, have been pretty responsible in saying that this is not a diagnostic test, despite those good figures. This is a test that needs confirmation with an invasive test. But I think they're making the point well that if that means less invasive tests because of a better false positive rate, then that's a good thing. So, you know, things like there are conditions that are famously mosaic, like Turner syndrome, and that will be very much a buyer beware with this form of testing. The other thing I didn't say is that 50% of women now in the private sector are having this testing done, so it's not like it's just a few. That's the figure throughout Australia.
Can I ask a question myself? If the mother is a carrier, so if the mother is a mosaicism Turner, and if you do the test, can you get the answer?
There are certain things that a mother can carry that can influence this testing, most definitely. Yeah, and there have been false positives on the basis of mothers having a chromosomal abnormality.
I was mainly thinking about the 21q deletion because some of them are carriers. So if you are going to look at this microarray and you know that the mother is carrier, so can you say that the baby is carrier or not?
So if the mother's got 22q,
yes.
No, you can't. You won't be able to say that because the free fetal DNA,
going to be, yes.
It may still be if mother and baby both have it, that the fraction is greater. But I think the number of cases for which that scenario has occurred is so few that they're not going to be able to confidently diagnose it. But again, the message, the really important message is it's not a diagnostic test. It's a really good screening test, but it's not a diagnostic test.
Is there another question? No.
The other thing, if I can just quickly say it, is that the people from Illumina who gave me a couple of those slides were in Adelaide 2 weeks ago, and they're about to publish 34,000 cases, and the positive predictive value is now in the 90s with improved technology. So again, if that test says that the baby's got Down syndrome, the likelihood that it does now is even higher on the newer technology. And it's heading in the direction, certainly for Down syndrome, that if you've got a positive NIPT, an absent nasal bone, a big nuchal in the first trimester, my personal feeling is that the time will come when that will be a diagnostic test. We're not quite there yet, certainly for trisomy 21, I mean.
I just put this algorithm up because that's really what the recommendation is at the moment. So if you do have a woman who does the first trimester screening and is a low-risk woman, so the risk come back less than 1 in 1,000, or if the risk come back very low, it's really no further testing. It has no further testing, so that's when the majority of women in the public system probably go by. If you do have a intermediate risk woman, so it's about 1 in 50, less than 1 in 50, and they come back that is really the risk to have a baby with Down syndrome is about 1 in 50 or above, then they can do the test, and then if the test come back negative, then it's really estimated about over 98 to 99% accurate, and therefore most majority of people will be advised to do not need to go ahead and do further amnio done. But if this coming back quite high risk women, so they come back, the risk is high risk for a Down syndrome, less than over 1 in 50, then that's when they can choose to do an IPT test, and if it's they really will be recommended that they should go and do the amniocentesis rather than just do the NIPT test. This is what I understand. That is basically what we're advising at the moment.
So most of you know who I am. I'm going to talk a little bit about how we in the public system tend to utilise this new technology. And as you've all heard, about 50% of the women in the private sector are taking up the NIPT, but it's a really expensive option, and it's not something that I can see coming into routine practice in the public system simply because of the cost. So this is me. You've all heard the term having a bun in the oven to describe a pregnant woman. And it's very apt, probably more so than you realise. To make the perfect cake, you need good ingredients. It's a good organic stuff, not the cheap home brand crap. You need good equipment, nice little artisan KitchenAid mixer, and you need a good oven. And if you hit the trifecta, well, you should end up with this. This is what we hope, okay? In reality, though, we all know that this doesn't always happen, and that things actually deviate from the plan. And it's very, very similar in obstetrics. So how do we bake a baby? Basically, we need good genetics. Now, unfortunately, we're not all blessed with the good looks of Elle Macpherson and the IQ of Albert Einstein. We also need good structures. The baby has to have a functioning cardiovascular system and spinal cord and brain. And finally, the baby has to be able to be cooked in a good environment. So you need a functioning working placenta. Now, the object of screening in pregnancy is to anticipate problems which may occur by catching them early and managing the pregnancy in a way to achieve the best result possible. That little person there. So in the public system, our current gold standard screen is the first trimester combined test. And what that takes into account is maternal age, the blood test that Michael was telling about with the free beta HCG, and obviously with that we take into account ethnicity, weight, smoking, etc. And the other thing that's included in this is the nuchal translucency, and that's done from 11 weeks to 13 weeks and 6 days. Now, it's a great test. We've all heard how good NIPT is, and it is, but this is also good. It's got a 90% sensitivity for Downs and a 90% specificity. The bloods that we look at are free beta HCG and PAP-A. Now, as well as being used to gauge the risk of aneuploidy, it also gives us really good information about uteroplacental function as a possible predictor for adverse outcomes in pregnancy, such as IUGR and preeclampsia. So what I'm trying to emphasize here is that although we've got the NIPT technology, that's not actually a substitute for this test. So the first trimester combined test is still a fabulous test. Then we talk about the 12-week scan. And again, the nuchal translucency isn't the only thing we look at here. Confirming viability is a really big thing. You know, up to 2% of pregnancies at the 12-week scan are actually found to be non-viable, so it's really important. The other thing is this scan allows us to date the pregnancy accurately. It allows us to identify multiple pregnancies and to assess chorionicity, and that's got significant implications again on how we manage the pregnancy. It also allows us to pick up structural abnormalities early, things like anencephaly, diaphragmatic hernias. You can see the heart and the stomach that's actually in the chest cavity here just next to it. We can also pick up things like abdominal wall defects, omphalocele and gastroschisis, and things that affect other systems like the genitourinary system. And here you can see the enlarged bladder in a prune belly syndrome. So as well as early recognition of structural abnormalities, the 12-week scan also allows us to recognize soft markers. And obviously everyone knows about the nuchal translucency. But there's other things like the nasal bone or absence of the nasal bone or hyperplasia of the nasal bone. There's the ductus venosus, which is a blood vessel in the fetal kidney. And this blood vessel feeds directly into the inferior vena cava. So it allows us to assess fetal cardiac function as early as 12 weeks. And when you can sometimes see abnormal waveforms in this Doppler test, that can be a marker for possible heart defects and would prompt us to think about doing an early morphology scan at 15 or 16 weeks. Other things such as tricuspid regurgitation or aberrant right subclavian artery, again, other markers for chromosome abnormalities. So you can actually see how much information we can get from this 12-week scan. So how does all this relate to clinical practice? Well, I basically think the best way to go in the public system is a contingent screening approach. We all know how expensive NIPT is, but we also know that it's a fantastic test if you can afford it. And so what we've been doing is encouraging women that want to have their first trimester screen, and based on the result of that, either guiding them into further testing or not. So women that screen low risk, for example, a risk that's less than 1 in 1,000, we've been guiding them to no further testing, go and have a morphology scan. And the women through the SAMHSA screening who've been screening high risk from 1 in 50 to 1 in 250, they're given the option of having the NIPT or proceeding straight to an invasive procedure. And there's been a huge pickup at Flinders. I'm not sure what the numbers are at the women's, but certainly at Flinders, for women who've been opting to have the NIPT. A lot of these come back low risk, and they've actually avoided having an invasive procedure. For women who screen high risk, that is with a risk greater than 1 in 50, I tend to counsel them in way of having either a CVS or an amniocentesis, because in these cases it's very likely that the NIPT is going to come back high risk. The other things we look at are the nuchal translucency greater than 3 millimetres. We can offer them a tertiary, an early morphology scan, looking in particular at the heart. And then there's the Pape screening of less than 3 moms, where we offer them uterine artery Dopplers at the morphology scan and growth scans in the 3rd trimester. So I think that the take-home message at this stage is that NIPT is fantastic, and it would be wonderful to be able to offer it to everyone. I suppose you can offer it to everyone, but it makes the whole screening process very expensive, and I can't see that the South Australian screening are going to foot the bill for this in the near future. So, is there any questions?
What do you recommend for the ladies between 1 in 250 and 1 in 1,000?
It's up to them. Up to them. I don't tend to see a lot of these women in the high risk amnio-CVS setting, but if I do see them in the clinic and it comes up, generally in the lower risk women, we don't tend to see them till after they've had their morphology scan. So bringing up something like this then just causes more trauma than it's actually worth. But yeah.
Joe, I agree with your comments about the 12-week scan. I don't think that's on the way out, and there's so much information that's gained from it, and we haven't really spoken much about what else an increased nuchal translucency tells you.
Can I just butt in for 1 second, Chris? I have actually noticed in the private sector that a lot of women, there are a couple of referrers that have now actually stopped doing the combined screen and are just sending women in directly for NIPT, which is a bit concerning when you think about the information that we can gain from that scan.
Yeah, I was just about to comment on that. So although we've spoken about it in terms of trisomy 21, you know, there's a long list of things that are associated with a big nuchal translucency. Congenital heart disease, about a 5-fold increased risk. Things that are obscure, that you wouldn't think are related, like cleft palate, significantly increased with a big NT. A long list of syndromes that are not going to be diagnosed on any other form of testing without specifically knowing what you're looking for. So when we do see an NT of 5 or 6 millimetres, you know, really high, the risk of that resulting in a bad outcome that isn't trisomy 21 is still high. So I think NIPT in that setting is going to be normal, but you still have an NT of 5 to deal with. And for example, 2 to 3% of those will have Noonan syndrome, which is a spelling error in a gene, and that is only detected if you very specifically look for that particular genetic change. So comments about the biochemical things, of course, I fully agree with you at the moment, but I think that it's the biochemistry's on the way out, and I think it's going to be gone probably within a few years as this technology gets better and cheaper. And I would anticipate that it will be government funded at some point, because it is something that will be able to be done in a mass-produced way within most tertiary hospitals.
Mm-hmm. So do you think people will just opt for uterine artery Doppler screening for placental function rather than the first trimester Pape beta HCG?
I think ultrasound is going nowhere. I think, as in, ultrasound is here to stay until better technology comes. I'm really just talking about biochemistry.
Yeah, I know.
Yeah.
You mentioned earlier in the sense of the people that wouldn't have a termination for down screening, and certainly in my practice, if that's what they say, I tend to say, well, let's kind of leave it alone. Do you think, though, that we should be doing, whether it's the serum screening and the ultrasound, and just not coming up with a Downs risk for them, but using it for the other markers, or staying away from it altogether?
it's very difficult ethically to do the test and then to get a result that's high risk and not disclose it to the patient. I know what you're saying. If it's not going to make any difference to the pregnancy, then I probably wouldn't be doing it at all, and I would be using other ways to look at the how the placenta is going to work, etc. I think we get quite a few patients who come in who have the 12-week scan to look at anatomy, to make sure the nuchal not thickened, that the heart's beating, that everything's where it should be, and don't want any screening for aneuploidy, and that's fine too.
Can I just ask you a question? It seems to me we're dealing with lots of perfect people with perfect opportunity for perfect ultrasound, but we know that there are an awful lot of difficulties doing good ultrasound at any gestation, certainly with increasing BMIs. So what impact is that potentially going to have if we're trying to do all these very detailed 12-week scans on everyone?
I would have expected that most places that do the first trimester nuchal screening would be doing this, well, up to this level of detailed scan as part of their assessment process. The issue with the BMIs is certainly very significant these days. We're actually scanning a lot more women using TV ultrasound, which gets fantastic visualisation of the anatomy, much better, in fact, than the TA scanning.
It's actually also, though, a problem at the other end, at the 19-week ultrasound, maternal obesity, isn't it? Because, you know, when I started in neonates, it was routine that your main morphology was done at 18 weeks, and now it's 19, and in some situations almost 20. And of course, what that means now for my service is that, you know, complex congenital abnormalities are being diagnosed at 20 weeks, and now that we're able to diagnose this stuff molecularly, we've got the ability to do it. We might need to send that DNA away to the US, and they may be able to get a result within a couple of weeks. But if we're not finding out until 21 weeks, and then have to do an amnio, then have to get the DNA, then have to send it to America, then have to get a result back, we're so close, that week makes a big difference to us. So I put a strong plug in for the morphology remaining at as close to 19 weeks as possible, and not just getting delayed and delayed and delayed, which it has, I think, largely because of maternal obesity.
Yes.
I was just wondering what the impact of maternal obesity is on the NIPT pickup rates, the detection rates from that, because my understanding is it has a really strong impact on whether they can find things or not.
What it does is it dilutes out the fetal fraction of the free fetal DNA. So often these women are called back to have blood samples redrawn. We have to have a maximum of 4%, I think it is, off the top of my head. Yeah.
So it's whether they can do it. It's test failure rather than an abnormal result.
Yeah.
I have a question in regard to access to high-grade ultrasounds. We encounter, with SAMSAS, it's difficult to get ultrasounds done through the state, and there's often a significant cost associated with an ultrasound not done through the state, and we end up offering biochemistry-only results for people who can't come up with the money for the screening. Cost is a significant part of this, and I just was curious where that's going.
You're right. It is very difficult to get bulk billed ultrasound. We've also stopped doing them at Flinders Medical Centre, and you guys only do the high-risk nuchals here, don't you? Yeah. Karen, can you comment on that at all?
I think for a long time the cost of doing ultrasound has been much higher than you'll get on your rebate. So unfortunately, it's not possible to offer that as a Medicare-only examination because it takes so much time and so much expertise and expensive equipment. And in terms of doing it within the public system, you have to look at how much can you provide and what goes if you can't provide everything. So that's been what's happened. I think it's unfortunate, but that's the way it is at the moment. Equally, you might have some patients who are quite happy to spend money on a 3D facial picture of their baby later in the scan, in their pregnancy, and they prefer to do that than pay the gap for their nuchal. So it's a personal choice as well from that point of view. That's not the case for everybody, obviously.
Just another thing to say, I think we've noticed at ADAX that often when a second opinion scan is requested for us as a tertiary centre, there's a real gap between the scan that identified the congenital abnormalities and then the referral in, and further to what I was saying before about the very narrow window where we may have a genuine chance of making a very specific diagnosis doing a genetic test is narrowed even further by the fact that we don't see the referral doesn't come through for like another week or something. So for the peripheral hospitals, and that's Hazel may comment as well, at ADAX it's almost a weekly event where for whatever reason there is a delay in the referral for the second opinion scan at a tertiary centre. I don't know whether you want to comment.
Yeah, well, I agree, yes. And a lot maybe depends on where the actual referrer sends it to. I don't know what information they've got out there, but yeah, it can go to, if it goes to the wrong place, then it could sit there for a week before we get it. So I guess it's important to send it actually to the right department where it will get dealt with.
With obesity becoming increasingly more prevalent in our population, I think we're all facing the issue, as you've mentioned, that the scans are being pushed later and later to get better anatomy from a transabdominal scan. I guess, what is there out there about the possibility of looking at doing transvaginal scans at, say, 16 weeks for these obese women in order to give us a greater window of opportunity to diagnose and therefore offer these women options?
That has been sort of mooted and talked about. It does make sense, but it's catching them and getting them in at the right time and being able to do it.
Thanks very much, Jay. Thank you. Just one thing I would just like to just ask. We've had lots and lots of information that is becoming increasingly confusing for us to understand. A group of people who've probably got a reasonable degree of understanding of anatomy, physiology and everything else. Seems to me that trisomy 21 is to some degree a spectrum disorder, and we talk about it as just a trisomy 21 or Down syndrome. But we know that there are huge spectrums of that too, and the community awareness of what trisomy 21 and Down syndrome is doesn't really often get confronted until you're actually, for the first time, being talked about in your first pregnancy. So I just wonder what anyone or the panel thinks about whether or not there needs to be also an antenatal or prenatal preconception education looked at, because it is very much an area, I think, of ignorance.
Down syndrome is interesting. I agree with you completely, there's a spectrum, but I think the universal thing is intellectual disability, and for a lot of people that's the line in the sand. And whilst there are people with Down syndrome at the lower end of the intellectual disability level, I guess, that's still it's, for non-mosaic Down syndrome, it's universal. We often ask people actually, did you think before you became pregnant what you would do, or did you think before you had your testing what you would do if you had a baby with Down syndrome? Because most people know about that condition, and it's surprising how many people just don't even give it any consideration whatsoever. All they want is to not have that negative thought. But we also have conditions that are worse than Down syndrome that we say to people, and we ask that question and they answer ambiguously with what they would do with this pregnancy now as compared to what they would do with Down syndrome. So I think you're right. I think people don't fully understand it. They have some understanding from TV and from perhaps knowing someone who had a child with Down syndrome, but there's a lot of room for improvement in the education. It comes down to time, doesn't it?
I just thought to just finish it off, to just show you just show you a form when you get the answer back from NIPT. And how it look like. This is one of the tests, which called Harmony, and in this specific one, they give you trisomy 21, 13, 18, and the sex chromosomes. So as you see, this is the same patient if you have a look, and as you see, if you look up there, it's written that the trisomy 21 came back at high risk, so there's greater than 99% that this baby is going to have a Down syndrome. And the others, I think it's just worthwhile to have a look because the result, if all of them come back, like low risk less than 1 in 10,000. And then down here, you can have a look at the male fetus. It's worthwhile to really look at it because that was the result you get. And sometimes they highlight the abnormal result up here and people don't see it. It just have recently happened. So the result come back as positive. It was highlighted, and they just look at the rest of it and come back as low risk, and they just said to the woman it was a low risk. But then the actual fact was a high risk, and it was highlighted so they didn't see. So it's just worthwhile to just really, really look all of them to be able to tell them. In this specific case, because it came back, the first trimester scan came back high risk, the second trimester, the NIPT came back high risk, so she chose to have amniocentesis. And at the time of the amniocentesis, they also find out quite significant other finding as a hypoplastic nasal bone, tricuspid regurgitation, echogenic bowel, and aberrant right subclavian artery, so cardiac issues. So basically, most likely, this result is coming back positive. So I just want to have a very quick talk as a continuation of what you say, to just have a discussion maybe from Hazel that when it comes back as positive, termination is one of the options, but it's not the only options. And I just want to have, for people who really don't know what to do and what to decide, could you just have a quick talk to us about what is available to support and what else available to gain more further information, not just specifically about trisomy 21 and all the other abnormalities and chromosome abnormality we find out.
Yeah, so obviously if, termination is one of the options, but not every option. She may wish to continue, so she would need a lot of support for that. We could advise her, we could suggest that she get in touch with the Downs Association of South Australia for, to talk to other families who have gone through similar experience. I think that helps a lot, actually talking to other families who have gone through similar, to get some idea. And as we know that with Downs there's different spectrums, so that's one thing that we would offer her. And obviously other support, again, family, social work possibly. And just...
some instance, I even have asked a neonatologist or a pediatrician to have a talk to them with some of the conditions to just help them to just have an understanding as well.
And obviously with high cardiac problem, we would obviously get any other specialist involved that might help them make a decision.
The genetics is always very helpful to really give a very good advice. Anything else you want to add, Chris?
I get criticised at ADAX for being negative, but I don't think I'm negative. I think when you counsel people, you shouldn't be directive in any way, shape or form. You really should provide information. And whilst I think sometimes the information comes across negatively because there are all these negative possibilities, it's not our job to shield people from the truth. It's not our job to sugarcoat it. It's not our job to make it sound worse than it is. And I think the more you do it, the better you get at being able to provide the information in a completely unemotional way that doesn't direct people either way. And you've got to take your own feelings about this whole thing completely out of the equation. Everybody has feelings about it, reflected by how you were brought up, what people have told you, your own personal experiences, all of those things. But it's got to be separated from that decision making.
The trouble is, Chris, you know too much. You'll tell them 500 different things that it could be. Very unlikely, of course, but yeah. It's a lot of information you give, and sometimes it's difficult to process.
I got a glimpse of you up the back there, and I knew you'd enjoy that. I think if you're doing it well, you're putting into context that those 500 things are rare and unlikely, but possible still, and that's really, I think, the way. So there's a difference between saying none of that's going to happen because it's rare, and there is this list of rare things that could happen. It's unlikely, but they're possible. And if that was me in that situation, I would like to know that there was 500 rare things that it could be, but they're unlikely.
It's actually difficult to put things into context, very, very difficult to put things into context. I mean, for example, if somebody goes through serum screening and through the SAMSAS program and has an amniocentesis or a CVS if they're high risk, if you look at the number of babies with Down syndrome diagnosed, it's about, for every 5 or 6 babies diagnosed with Down syndrome, 1 normal baby is going to be lost from the invasive test. I suspect many people actually don't realise that when they sign up to go through the serum screening process. And you can debate the ethics of that. That's too high pay grade for me. If even NIPT, if you look at the false positives in NIPT, and presuming they need to go through an invasive procedure to diagnose whether or not it is or not, it's about every 50 babies diagnosed with Down syndrome, 1 normal baby is going to be lost. So if you choose NIPT, you've still got those figures to face. And you put that into context, it often makes people think very differently. And it really needs a very holistic view to put that across.
Perfectly put into words what I'm saying is that somehow does have to be communicated to people.
Yeah, and it's hard.
And of course, when you're probably talking to them, having talked to women after they've spoken to someone, they're only remembering because they only hear a word or so, and then they say things like, after that information, it takes so long to actually be digested. But what needs to happen and decisions that need to be made can happen quite quickly. And so, I mean, like you quite rightly said, Dr. Wheatley, people having some idea beforehand about and a discussion, but pregnancy doesn't always happen nice and neatly, does it? That someone meets somebody and they have a nice discussion about what they would do and what all the situation would be. Then they get pregnant and then, they know exactly what they're coming up for. So whenever we deal with anybody, our language that we use and our body language is always really important because it's amazing what they take away. And it's only a tiny bit, and they will need to come back and talk to somebody else, which is why it's really important that there are midwives around or doctors or geneticists or whoever it is that person may need, or you might go over the same conversation many times before they make that decision, but it will be with them for the rest of their life as to what decision they actually make.
On a completely different note, anecdotally, I'm hearing that the reason there's such a high uptake in the private sector is because women want to know what sex they're carrying as early as possible, and they're not actually aware of the other information that they're going and decisions. Do you have any view on that? Because you said on the results, it's one of the 4 or 5 things is the sex of the baby.
Well, there is, but they have to pay extra in our rooms to find out the sex. I wasn't aware that was one of the reasons people I mean, it's a hell of an expensive way to find out gender.
Women are doing ultrasounds at like 8 weeks, and there's a lot of discussion about the pubic position, which way it goes and where the placenta is, and the women know about these aspects of it, so something is educating them. But and I said it's anecdata, but that's what's driving women. They don't really necessarily want to know about trisomy. They're not aware that that's the information they're going to get.
Well, these women, the ones that we see, presumably have been counselled by their private obstetricians, as they actually have to sign a consent form before having the bloods done. So I would like to think that they knew what they were signing up for and not just to find out the fetal gender.
Just back to the question earlier, we were discussing about trisomy 21 and that a larger percentage of the women spoken to are concentrating on their intellectual disability. Is there ever the situation where you can discuss, for example, in this case, with the cardiac function of this baby, is that ever likely to outweigh the intellectual disability in any way, like the long-term viability of the baby after birth?
So 50% of kids with Down syndrome have got a congenital heart lesion, but mostly not so serious that it needs surgery. But, if on ultrasound it's very serious and the child's going to need to go to Melbourne on day 2 of life, I think that very much affects people's view, very much, quality of life. We're certainly here for the more severe cardiac lesions, people are presented with exactly what is likely to happen in the days after birth, and families are able to take that on board. And I think probably in some situations that is the clincher. is knowing that the baby's going to have to go to Melbourne. You know, for example, hyperplastic left heart, 3-stage operation, 50% mortality at each stage. That plus the knowledge that the child's got Down syndrome and that, you know, it may not be operable because the child's got Down syndrome would make a big difference.
Thank you.
I just wanted to answer the private sector question as an obstetrician that only works in the private system, and I do a lot of obstetrics. We're nowhere near 50% uptake on the NIPT. I'd say maybe getting close to about 10% in our practice, and there's 3 of us that all work together. So it's only just starting to become a bit more popular, and particularly with the decrease in price from the 1,000 down to the 500, and not any of our patients have ever specifically come in saying, I want that because I want to know the sex of the baby, and we wouldn't give it to them, I don't think, on that basis alone, but that's certainly not the truth is what's happening.
Hi, I work in the private sector, and I can honestly say not 1 in 2 women are coming through having had that screening test. And as well, something that needs to be taken into consideration is a lot of our women are in their 40s, some of them are 50, having their first babies. Some of them are a large percentage are also IVF babies, women who've undergone many, many years of wanting to get pregnant. So there's quite a few factors that need to be taken into consideration, and the women that I've seen have no focus whatsoever on the sex of the baby when they've had the test. Most of them are around elderly primips, IVF, and wanting to know or prepare themselves one way or another what's going to be happening in this pregnancy as well.
So the figures are for Australia rather than for South Australia. And I think there's a lot of this is going on in Sydney and Melbourne. But it was presented with the Human Genetics Society of Australasia meeting was in Adelaide a couple of weeks ago, and a couple of speakers presented the figures individually.
Chris, do you think it is reasonable for us to offer NIPT to low-risk women rather than the SAMHSA screening? Because at the moment I'm not. It's just to those that maybe have had a previous pregnancy, are older. Is it reasonable to offer as a first line and then they just then do a 12-week scan to look at the nuchal?
Are you saying you're not offering first trimester screening to those people though?
No, so everyone gets offered first trimester screening, but I only discuss NIPT with older women, women whose 12-week screening comes back high risk, or those who've had a previous miscarriage or pregnancy, which was trisomy 21.
If you take the money out of it, the logic isn't a lot different though, is it? That's the problem. Between first trimester screening and NIPT, the logic in doing that in a low-risk population is not different. So that, to me, is where the argument gets into trouble, because it's about money then and nothing else. The original studies have mostly all been in the high-risk population, but more recently, and including the stuff that was presented just a couple of weeks ago at the International Society of Prenatal Diagnosis in Brisbane, is now in the low-risk population. And with better technology, the numbers in the low-risk population are matching up to the numbers in the high-risk population in terms of sensitivity, specificity, negative predictive value. So to me, it's sadly about money, and there's no logical difference to me in offering NIPT, not offering NIPT, or saying it's available, yet then still doing first trimester screening. Michael, I'm interested in your thoughts on that.
I didn't understand what you just said. But that wasn't, I didn't understand what you were just describing.
I'm in trouble if you don't understand. Did you understand?
So, I mean, basically, if you should offer it all, then it's up to them to decide.
Well, I think they need to know it's there, because you've made the clinical decision that even though they're low risk, you want to do first trimester screening. To me, that it's available, and there are superior aspects to it over biochemical screening. Many people will not be able to afford it, but it's available. I just thought it would be a good forum to spend 5 minutes on this, because we're getting more and more referrals, questions from obstetricians particularly about, is this situation something that we would do this new test called a microarray in? For those that haven't heard of it, I'm going to explain it hopefully clearly. The terminology is basically a microarray, or array is shorthand for array comparative genomic hybridisation, array CGH.
In summary, and that's really all you need to remember about what the test does, it allows detection of small gains or losses of DNA, chromosome material, much smaller than can be seen on a standard karyotype. Karyotype, the minimum amount of missing genetic material, for example, is 5 million bases of DNA, and it's down on microarray to as small as 50,000, which is like within a single gene in the genetic code, rather than big chunks of chromosomal material. That's a karyotype. It's been around for about 50 years, and many people, including me, think of it as being like an aerial view of the genetic code. And if you look at the women's and children's there in the middle, if that happened to be missing, you would see it on a karyotype. It's like a major abnormality in the genetic code. And when you've got a major abnormality in the genetic code, always it's going to be associated with a bad outcome. FISH came along, which is like targeting a building, a very specific building in that genetic code, a very specific part of the genetic code. And microarray now, to use my analogy, is down to the level of a book on my bookshelf in that building, and maybe a few pages ripped out of a book, or even an extra book perhaps put on the bookshelf, which is equivalent to absence of genetic material or extra genetic material in the code, which we now know in the paediatric population is the explanation for 15% of intellectual disability, 15% of autism, and 15% of congenital abnormalities, where the karyotype, the 50-year-old test, is normal, okay? So the natural extension of that is, well, why aren't we doing it in pregnancy? If it detects 15% of the cause of intellectual disability in children, why aren't we doing it in pregnancy? And the answer is we are in certain situations. Just to give you an idea of what it detects, the things like trisomy 21, where you've got a whole extra chromosome, it will certainly detect. Tiny little missing bits or extra bits it will detect. And even though you've got a tiny bit of a chromosome missing, that can still be just as bad as having trisomy 21. For example, Cri-du-Chat syndrome, a little bit of chromosome 5 missing, is easily as bad as trisomy 21 in terms of intellectual functioning and the risk of congenital abnormalities. It won't pick translocations unless they're unbalanced. And basically the top two things are really the most important things to know. There's now a flood of studies of looking at microarray in pregnancy because of its superior detection rate. This is one that was published just very recently by Lisa Schaffer. This particular one looked at individual abnormalities, like, for example, a heart problem. What's the likelihood of finding an array abnormality when the karyotype has been normal? I'm not sure how well it projects up there, but you can see here, basically, for example, structural abnormalities in multiple systems, there's a 10% extra pickup rate from microarray here. So if you've got, you know, for example, maybe a hole in the heart, VSD, and a missing thumb. If you had that on ultrasound, you could see that clearly on ultrasound. The karyotype is normal, then 10% of the time there'll be an extra finding on array that enables a diagnosis to be made, which usually, not always, but usually again, is associated with an intellectual disability as well, because there's missing genetic code material. And there's just a long list down here of things that increase the pickup rate on microarray. And again, long list of things, all of which have a either significantly increased or slightly increased risk of being abnormal when a karyotype has been normal already. One of the difficulties is that it's got the ability also to find out stuff that you don't want to know. And one of the reasons we're cautioning slowly with this is that this is what's happened in the paediatric population in this hospital since the test started in 2010, is that when I last looked, we had done 5,100 of these in children, and 5 of the 5,100 had significant genetic abnormalities detected by the test which give them a predisposition for cancer, either later in childhood or in adulthood. And that's hard enough when you've got a child for whom you've done a test because they've got learning difficulties or they've got autism. It's hard enough to then have to say to the family, this child's got a cancer, a very high cancer risk 20 years from now. But dealing with that in pregnancy, when you might be making decisions about life and death for a couple based on something that is detectable on this testing. So this is where, again, pre-test counselling is hugely important. These are all, this one here is called von Hippel-Lindau condition, which is a well-known but rare cancer syndrome where you get brain tumours, eye tumours, various other things. So the process at the hospital at the moment is that we certainly are doing many arrays now, particularly for congenital abnormalities, but we're counselling everybody, as in we being the genetics department, either face-to-face or by phone, about what the test is, what it involves, and what the results mean, including things like a variant of completely unknown significance that could come back on a prenatal array, where it's even worse than getting an answer sometimes, is getting something that we don't really know what it means, and they're trying to make a decision about continuing or not continuing. So that's really what microarray is. It's a far superior test to karyotype in resolution, but with it comes significant interpretation difficulties.
Would you just like to comment on its use in terms of investigation of stillbirth or perinatal death?
Yes. That's a really good question. Essentially, since the same time as, well, about a year after Array was introduced and funded by Medicare, I didn't mention, in the paediatric population, we started doing microarrays on all autopsy specimens here at the hospital. So we've now got about 4 years of experience of doing this, and the detection rate on Array above and beyond karyotype is again 10% for 2 congenital abnormalities and about 6% for 1 congenital abnormality. So we're in a privileged position to be able to offer that, with many diagnoses being made that weren't previously made for congenital abnormalities. And usually, fortunately, being able to say to parents the likelihood of this recurring is very low because it's a one-off genetic event that hasn't been inherited usually.
Everyone's exhausted with information overload. Thanks to Amy and Morgan for their presentations. And in particular, I would like just to thank our panellists, Michael, Jay, Hazel and Chris. Thank you very much.